Assalamualaikum and good morning. So I'm Dr. Nurul Ibrahim from Department of Pathology, University Science Malaysia. So in this video, I will share with you the practical pathology of CNS tumors. But before that, I would like all of you answer my quiz, and in which the link I have provided in the chat box below. My objective for this session is for all of you to recognize the common brain tumor. These include glial tumors. Under the glial tumor, we have astrocytic tumors, we have oligodendroglial tumors, ependymal tumors, and choroid plexus tumors. I also would like all of you to appreciate the morphology features of embryonal tumors. In this video, I will share with you medulloblastoma, and I will also share the histology features of tumor arising from meninges, which is meningioma, and nerve sheath tumors. So we start with pilocytic astrocytoma gross features. Pilocytic astrocytoma preferentially located at the posterior fossa and also the cerebral midline structure. And other from that, there is also usually located in the hypothalamus and the brain stem. In this case, the tumor located at the cerebellum. This is a cerebellum. So the tumor is generally well circumscribed. You can appreciate that the tumor is easily differentiate with the surrounding brain tissue, with the surrounding parenchyma, and it is composed of this solid and cystic, in which largely cystic, and we can see that at the periphery there's a solid component. This is also a cystic component. This is another gross picture of pilocystic astrocytoma. As we know that pilocystic astrocytoma is common in children and adolescent. So when we get tumor in a children located in the cerebellum, you should put pilocytic astrocytoma as one of your differential diagnoses. In this gross example of pilocytic astrocytoma, again we can appreciate that the tumor is generally well circumscribed. We can easily distinguish the tumor with the surrounding cerebellar parenchyma, and in this gross picture, the tumor is largely cystic with associated mural nodule at the periphery. This is the solid component, and also this one. Let's see the histomorphology features of the pilocytic astrocytoma. How the pilocytic astrocytoma look under the microscope. In this low power view, we can appreciate the typical biphasic pattern of pilocytic astrocytoma. We can see that this is the loose microcystic area, and again this is also the loose microcystic area. We can recognize the microcyst. These spaces that present within the tumor we call this as a microcyst. And alternate with this loose microcystic area, we can see the quite relatively compact area. They are alternating with the loose microcystic area, and in this compact area, usually we will find a rosetta fibers. So in this low power view, we can also appreciate that this tumor is well vascularized. There is so many blood vessels. This is blood vessel in which the lumen we can see the presence of red blood cells, and the blood vessels in the pilocytic astrocytoma is hyalinized. The surrounding blood vessels, there is a hyalinization. This amorphous eosinophilic material, hyaline materials. we go to higher view, we see closer, in which we can appreciate the cellular details of the tumor cells. Cells of the pilosity astrocytoma in the loose microcystic area usually rounded and oval, and the cells in the compact area usually more spindle and elongated. We call this as a piloid cells. And in this in this high power, we can also appreciate the presence of these blood vessels, in which the blood vessel is hyalinized. This is hyalinization of the wall of the blood vessel. And in this power, we can also see the presence of these hyaline globules. This is hyaline globules. It is a eosinophilic materials present in the cytoplasm, intracytoplasmic eosinophilic material. This is another hyaline globules. Hopefully that you can see these cellular details, even though maybe I think a bit blur and not that sharp, but I believe you can try to understand and recognize the cellular details and also the presence of these hyaline globules. This is closer view, higher magnification of the pilosity astrocytoma, so we can identify the cells, the rounded to oval cells with fine chromatin pattern. And here we can see there is a presence of these rosental fibers, in which it appears like a corkscrew hyaline eosinophilic material. This is a weak rosental fibers. And this is another closer view of pilosity astrocytoma, in which fibrillar background due to presence of this fibrillar cytoplasmic process of the neoplastic cells. And we can appreciate that this is a rosental fibers. And another pictures to show rosental fibers and hyaline globules. This is very apparent rosental fibers. There are so many rosental fibers. This is a brightly eosinophilic rosental fibers. All of these are rosental fibers. They can be tapered, corkscrew shape, brightly eosinophilic hyaline masses. They are all intracytoplasmic. And in this slide, we can also appreciate the presence of these hyaline globules. This is also brightly eosinophilic materials, intracytoplasmic eosinophilic materials. This is another view of pilosity astrocytoma. Again, we can appreciate this is a low power of pilosity astrocytoma. This is hyaline globules. And we can appreciate that the cells is oval, rounded, and some are elongated and spindled. So another view to share with you how the hyaline globules look like. There is many hyaline globules over here in this slide. All of these are hyaline globules. They are a brightly eosinophilic materials. When you see this, correlate with the clinical and radiology, I think you can easily diagnose this case as a pilosity astrocytoma. So another low power view to show you the pilosity astrocytoma. The background is fibrillar because it is a astrocytic glial tumor. So background of this we can appreciate that there is a cytoplasmic processes, and the cells, the cellular details, they are rounded, in which some are oval. This is oval. Okay, this is the virtual slide that I will show you at the end of this video. So next we go to our anaplastic astrocytoma. Anaplastic astrocytoma is a WHO grade 3 astrocytoma. Compared to gross morphology of pilocytic astrocytoma, anaplastic astrocytoma is ill-defined. We can't really delineate the tumor with the surrounding structure. They are ill-marginated, ill-circumscribed, and here you can see that this tumor are pushing the ventricles and causing the midline shift. The surface show homogeneous whitish to slightly grayish area, but there is no apparent gross necrosis. This is important so that we can differentiate with gross morphology of the glioblastoma. This is the view under the microscope. How anaplastic astrocytoma look like? They are very cellular. Compared to pilocytic, they are hypercellular. And they exhibit very marked atypia, in which we can see that the cells compared to the adjacent cells are pleomorphic. They are different in terms of size and shape. Some are small and some are big, and they have a very irregular nuclear outline. We can appreciate that the cells are very irregular, the nuclei are very irregular. They are irregular with coarse chromatin pattern. They are so different with each other. The shape are different and the size is also different. And we need to find mitosis. Usually the mitosis is brisk. This is a closer view of anaplastic astrocytoma. Here we can appreciate there is a presence of mitosis. Mitosis is easily seen. This is mitosis, and the cells are very pleomorphic. They are pleomorphic with coarse chromatin pattern. The background still fibrillary because they are astrocytic glioblastoma. And when we see cells which is very pleomorphic, very atypical with brisk mitosis, we need to find if there is any evidence of necrosis or microvascular endothelial proliferation. Why? This is important because we want to differentiate the tumor from the glioblastoma. So let's see how glioblastoma WHO grade 4 look like. Grossly, it is defined, ill-marginated. Compared to anaplastic astrocytoma, here the surface look pinkish, area of soft, and grossly we can appreciate the presence of necrosis. All this yellowish area is a necrosis. So presence of necrosis, this define the glioblastoma. They are large, compress the ventricle and also causing the midline shift. This is a histomorphology features of glioblastoma. They are very pleomorphic. We can appreciate there is a presence of this large bizarre giant cell, easy to see mitosis, and the cells are very pleomorphic, coarse chromatin pattern, and some are hyperchromatic. And to diagnose glioblastoma, we need to find the presence of either microvascular endothelial proliferation or necrosis. Presence of any of these two will lead to the diagnosis of glioblastoma. In this slide, I would like to show you the presence of microvascular endothelial proliferation or glomerular blood vessel. This is microvascular endothelial proliferation. Normal blood vessel will be only lined by single layer endothelium. But in this case, the endothelial lining of the blood vessels proliferate and they occupy the lumen and causing only presence of these small spaces in which these resemble the glomerulus. That's why we call it as a glomerular blood vessel. Let's see how what is the closer view of these glomerular blood vessels. See, in normal blood vessels, this adjacent normal blood vessels, it is lined by only a single layer of endothelium. This is a nucleus of the endothelium, very flattened single layer of endothelium. But in the blood vessel that exhibit glomerular or microvascular endothelial proliferation, the endothelium that line these blood vessels is proliferate. They causing multiple layered, not monolayered like these blood vessels. And all these endothelium, they occupy the lumen, causing in leaving only these small spaces in between. This is what we call as microvascular proliferation. So when you see these glomerular blood vessels or microvascular endothelial proliferation, you can diagnose this glial tumor as a glioblastoma. This is another example, another pictures I would like to share with you how this microvascular endothelial proliferation look like. This is one microvascular endothelial proliferation. This is another, and this is also another one. Another characteristic of glioblastoma is the presence of necrosis. We can this is area of necrosis, and we can see that the tumor surrounding the necrotic area is relatively dense compared to this area. And when you see this, you can call this necrosis as palisading necrosis, in which this dense area appear like the tumor is palisade and surround the blood vessel. Surround the necrotic area. And later I will share with you this visual slide of the glioblastoma. And another glial tumors that I would like to share here is oligodendroglioma. This is commonly arise from cerebral hemisphere, and the most common location is the frontal lobe. And most of the patient will present with seizures. So under the microscope, the oligodendroglioma has this specific specific features in which you can recognize by low power. You can see that the tumor is uniform. They are similar in terms of size and shape, and they have these fried egg features in which there is a perinuclear halo and clear and empty cytoplasm. These appear like a fried egg, and they are so uniform. They are similar to each other. And there is also a dense network of delicate capillary. This is a delicate capillary, and this small vessels capillary is branched. They are well vascularized and so numerous blood vessels that is branched. And these small capillary blood vessel we call as a chicken wire. It look like a chicken wire. Okay, another view of oligodendroglioma. You can see here is the blood vessels. There are branch blood vessels and look like a chicken wire. Again, another chicken wire blood vessels. Easily recognized. And the cells look like a fried egg appearance. Because of this perinuclear halo and empty clear cytoplasm, they look like a fried egg. And another clue that can help you in diagnosing the oligodendroglioma is the presence of this occasional microcalcification. So when you see a glial tumor that has this uniform monomorphic appearance in which the cells has characteristic of in which the cells look like a fried egg, and you see many blood vessels, many branch chicken wire blood vessel with presence of this microcalcification, you can easily diagnose this case as oligodendroglioma. This is another closer view of oligodendroglioma. Very apparent fried egg appearance, perinuclear halo due to clear empty cytoplasm, and the cytoplasmic membrane is well defined. You can see the cytoplasmic membrane. They are sharply outlined. And all the cells, all the nuclei is round and monomorphic uniform. This is another closer view of oligodendroglioma, in which in this view you can appreciate the presence of blood vessels. This is the blood vessel. This is a delicate small. They are branch blood vessels. And this view highlight the chicken wire appearance of the blood vessels. And the neoplastic cells is very uniform, rounded nuclei, and very apparent clearing of the cytoplasm, perinuclear halo, causing they look like a fried egg appearance. Then we would like to see the glial tumors. This is another glial tumors, ependymoma. Ependymoma can develop in patients of any age, and it commonly occurs along the ventricular system. Histology, it shows the presence of small cells. This is very small, monomorphic, uniform cells. They are small and monomorphic. In a background fibrillary matrix, but because of they are quite hypercellular, the background fibrillary matrix are not so apparent. And another characteristic of this ependymoma is the presence of pseudorosite. This is all our pseudorosite, in which there is a lot of hyalinous blood vessels, and these hyalinous blood vessels are surrounded by the tumor cells. And okay, this is a better view of a pseudorosite, in which we can appreciate there is a blood vessels. Sorry that this picture look a little fade, but again I believe even though it's not so sharp, you can appreciate that this is a pseudorosite because there is a presence of blood vessels. There is many blood vessels, and all of these blood vessels are surrounded by these tumor cells, and in between these tumor cells and the blood vessels there is presence of this enucleated zone. This is a closer view of the pseudorosite, ependymal pseudorosite. This is a blood vessel because we can appreciate that there is a presence of red blood cells within the blood vessels, and the blood vessels is surrounding by these tumor cells, and with the presence of this perivascular and nucleated zone. There is no nuclear within this perivascular zone, and later you can appreciate there is a neoplastic tumor nuclei surrounding it. Later I will share with you the ratio slide of this ependymoma. Then we go to our last glial tumor. It is a gross picture of correct plexus papilloma. This is a benign ventricular papillary neoplasm. It derived from a correct plexus epithelium. It has very low or absent mitotic activity. So from this picture, we can appreciate that this tumor look like a cauliflower. They have this exophytic cauliflower-like appearance. And in this picture, we can appreciate there is a correct plexus papilloma arising at the posterior of this third ventricle, and this causing an obstruction and causing this ventricular dilatation because of the obstruction. This is the low power view of the correct plexus papilloma. We can appreciate that this is a well differentiated papillary pattern, fibrovascular core. It has these vessels within the vascular core, and all these fibrovascular core are covered by this neoplastic cells, single layer of this cuboidal to columnar epithelium. All of these are fibrovascular core. All are fibrovascular core that has blood vessels within this fibrous core. So another view to show you, this is a exophytic papillary structure. This is a papillary structure or fibrovascular core. This is fibrovascular core. And all of them are lined by this single layer of epithelium. Just a single layer epithelium in which this epithelium, these are bland cuboidal to columnar, lacking or absent of mitosis. They are usually occupy the ventricular system. They are located within the ventricles. So later we see the visual slide. And let's go to the embryonal tumor, and I will share with you the common embryonal tumor, which is medulloblastoma. It commonly grow in the cerebellar parenchyma, or sometimes they can grow into the fourth ventricle. Commonly occur in children, and they are embryonal tumor. They are a tumor that have a very primitive appearance because they look small, small round blue cells, and they have these very large nuclei. They look very uniform, small and uniform. But there is also variant of anaplastic medulloblastoma, in which they appear. Share with you the classical features of medulloblastoma. They are uniform, they are rounded, with scanty cytoplasm. The cytoplasm is very minimal and scanty. They have this very high NC ratio, very high nuclear to cytoplasmic ratio because of this scanty cytoplasm. They appear small. They are uniform. They has this very primitive looking, and the cytoplasm is very scanty. They have this brisk mitotic activity. Later I'll show you the visual slide of this medulloblastoma. But when you see tumor in children located at the posterior fossa and the cerebellum, having these primitive looking cells, small round blue cells with very scanty cytoplasm, brisk mitotic activities, you can diagnose this as a medulloblastoma. This is a tumor arising from the meningium, arising from the meninges. This is meningioma. Meningioma exhibit wide range of histology appearance. There is a lot of variant of meningioma. There is many subtype. And the most common are meningothelial subtype. This is meningothelial subtype of meningioma. And the spectrum of there is a spectrum of the grading of the meningioma depends on its subtype. But for your level, I think able to recognize the meningothelial meningioma or able to recognize this as meningioma is fair enough. Meningothelial meningioma fall under WHO grade 1. In this low power view, we can appreciate that the cells is arranged in these lobes exhibiting a whirling pattern. It's all arranged in lobules with a whirling arrangement. In this higher view, we can appreciate that there is a presence of this samoma body, this calcification, and the cells is round to oval with this syncytium cytoplasm, in which we can't really delineate the cytoplasmic membrane. They appear in continuous with one another. This is another microscopic features of meningioma. This is the whirling pattern in syncytium arrangement. It appears that this is the nucleus, and it appears that the cells, adjacent cells, sharing this cytoplasm because the cytoplasmic membrane cannot be delineated. That's what we call as a syncytium. This is another pictures to show to you. This is a samoma bodies, lamellated. Okay, in this closer view, to see the cytology feature, the cytology details of the meningothelial cells. The cells has very bland looking. Have this uniform appearance, round nuclei. Some are oval, but again they still uniform, no pleomorphism. And the cytoplasm are syncytium. We can delineate the cytoplasmic borders. Later I'll share with you my visual slide. So let's go to the nerve sheath tumor. This is histology features of schwannoma. This is our last tumor today. So in this low power view, we can appreciate that there is presence of this antennae A and antennae B, very characteristic. Before we go to the histology features of the schwannoma, grossly, schwannoma usually, typically, it is encapsulated nerve sheath tumor. It composed of entirely well-differentiated Schwann cells. This is a benign tumor. It commonly occur. It rarely occur intracranial, but again there is a case of intracranial schwannoma. It usually occur outside the central nervous system, in which the peripheral nerve in the skin and subcutaneous tissue are the most common affected, commonly outside the central nervous system. And 85% of nervous system schwannoma occur in the cerebellopontine angle and spinal nerve root tumor. Back to the histology features of schwannoma. They have these antennae A, in which composed of this compact area. This is antennae A area, hypercellular area. And there is a presence of this Anthony B area, in which this is a hypocellular area. Cells in this compact Anthony A area usually is spindle and elongated with you can appreciate the wavy nuclei with tapered end. And the cells in this Anthony B area are more oval with indistinct cytoplasmic process. This is a closer view of this schwannoma. We can appreciate that this is a cells in the Anthony compact area, Anthony A area. The cells are spindled with tapered end. They appear wavy. This is the Anthony A area. And the cells in the Anthony B area they are more hypocellular and they are more rounded or oval compared to this cellular Anthony A area. And this is a very special characteristic of the schwannoma, which is a verrucate bodies. We can observe that in these verrucate bodies usually occur in Anthony A area. We can appreciate that the verrucate bodies is composed of these neoplastic Schwann cells that is in which the nuclei is lined in parallel. This parallel nuclei forming nuclear palisade. And because the nuclei arranged parallel here, they form area of anucleated zone. This is area of anucleated zone. And alternate this palisade area with area of anucleated zone. We call this as a verrucate body. Later, I think I will share the virtual slides of all tumor that we discussed here. So in this low power view, we can appreciate that the tumor composed of the compact cells, compact area in my left hand side, and in my right side, it is shows the loose microcystic area. When we try to focus at the compact area, this is the compact area. The cells are composed of spindle elongated cells. This is a beloid cell. Later you can try to see yourself. I will share the link. And when we see at this area, this is where you can appreciate the presence of microcystic loose area. So there is a many empty spaces in between the cell, and the cell are more rounded to oval compared to the cell in the compact area. So the background is fibrillary. In this glial astrocytic tumor, when you see a fibrillary background, you can give a clue that this is a astrocytic tumor. Then we need to try find the presence of Rosenthal fibers and hyaline globules. Sorry that I cannot use my pen in the setting. At the center, you can see the hyalinized blood vessel. This is mostly microcystic loose area. And many of the areas show similar morphology. They have a compact and alternating with the loose microcystic area. You can appreciate the fibrillary background here, and there is a bit Rosenthal fibers and hyaline globules at the center. try to find all these features, the hyaline globules and Rosenta fibers, in the slide. You need to scan all the slide area. When you receive a slide, or when you are given a slide later in the exam, you need to look at all the slide. You need to look at all the area in the slide. This is hyalinous blood vessel, and this area is mainly composed of the microcystic loose area. At the center is an alternating compact area, in which we can appreciate that this area, the cell is more spindle and elongated. This is what we call as a piloid cell compared to the cell in the microcystic area. And there is also presence of Rosenta fiber, in which you can see brightly eosinophilic material, either with tapered end or corkscrew, but there is no hyaline globules here in this area, in this focus. So later you see the slide, you see the visual slide by yourself. So we go to the second slide. This is a slide of glioblastoma. In this low power, in this view, you can appreciate it is composed of multiple fragments. When you go closer, you can appreciate that this tumor is very cellular. It is hypercellular. It appears bluish because of the cellularity. And in this low power, you can also appreciate the presence of necrosis. At the center, there is a necrosis with associated hemorrhage. Again, this also at the center. I show you. This is the necrosis. So the presence of necrosis in the associated tumor define the glioblastoma. When you correlate clinically, and when you see this very pleomorphic cell at the center, I show you this is very pleomorphic. They are different in terms of shape and size, and they have this fibrillary background with presence of this is necrosis. Even though it's not a palisading necrosis, you can't really appreciate the dense cellularity at the periphery of the necrosis. Any type of necrosis any type of necrosis is a clue, is a characteristic for glioblastoma. And over here, I show you at the center is a microvascular endothelial proliferation. You can appreciate that there is a spaces within this capillary containing blood vessel, and you can see that the endothelial is more than one layer. So presence of either two, necrosis or endothelial proliferation, is needed to diagnose glioblastoma, or it can present both. So let's see the other part of this slide. So again, you can appreciate the cellularity. It is very hypercellular. The cells is very hyperchromatic. Easily you can appreciate the mitosis. At the center is one mitosis. So glial tumor, astrocytic tumor with this pleomorphism and breast mitotic activity, and the presence of necrosis and also endothelial proliferation, you can easily diagnose this case as a glioblastoma WHO grade 4. Let's see another fragment of this tumor. Here, you can appreciate the large area of necrosis. This is at the center is necrosis. This is another necrotic fragment. They are very cellular. It appears very blue because the cellularity. It is well vascularized. You can see many blood vessels. Even though not all the blood vessels is showing exhibit endothelial proliferation, presence of any of even a focus of endothelial proliferation is characteristic of glioblastoma. In this view, the blood vessel is not displaying endothelial proliferation. So our third slide is a slide of oligodendroglioma. Okay, in this low power view, you can appreciate that the cell show a cytoplasmic clearing. They are uniform and they are arranged in sheet. Even in the low power, the cytoplasmic clearing is apparent. When we try to see closer, we can observe that all the cells are uniform. They have these round nuclei. They don't exhibit pleomorphism. And there is a perinuclear halo due to the cytoplasmic clearing. And this is what we call as a fried egg appearance. And in this low power, we can also appreciate there is many delicate capillary blood vessel, and this delicate capillary blood vessel is easily branched. This is what we call as a chicken wire blood vessel. We go higher to see further details of the cytology. So you can confirm that there is no pleomorphism. Again, you can appreciate that the nucleus is oval and rounded. There is no different in terms of shape and size. All show similar features, fine chromatin pattern. There is no nucleoli, and there is many capillary, delicate, small size blood vessel. And when we scan all the other area, they show similar features. So when you see these cells, I think the fried egg appearance is very apparent. You can diagnose this case as a oligodendroglioma. We go to our fourth case. This is multiple fragment of tumor. We go to the low power first to see how this tumor arranged. Sorry. Okay, this is a case of appendymoma. In this low power, I think the most prominent features in this slide is the presence of pseudorosette. As we know that the pseudorosette is composed of the blood vessel. You can appreciate that this is a blood vessel surrounded by the tumors, and between this nuclei of the tumors and the blood vessel, there is presence of a nucleated zone. So this is a pseudorosette. It's very obvious there is so many pseudorosette here. And when we see the details of the cells has this uniform nuclei, round to oval nuclei. There is no perinuclear halo like oligodendroglioma. The blood vessel in appendymoma is large compared to delicate small capillary size blood vessel in oligodendroglioma. And you can appreciate that they are all bland looking, no pleomorphism. Rarely you can appreciate mitosis. The blood vessel, they are well vascularized, but the blood vessel compared to oligodendroglioma, blood vessel in ependymoma is larger, and they are part of this pseudorosette. When we scan through all the area, they showing a similar features. This is a correct plexus papilloma. In this low power, you all can observe that they are composed of this fibrovascular core. They are papillae, branch, and all these papillae, all this papillary structure are lined by the cuboidal to columnar neoplastic cell, and this cuboidal to columnar neoplastic cell exhibit a bland nuclear features. When I say bland, because there are no pleomorphism, rarely or they are absent mitosis. There is no bizarre larger cell. So this is at the center here, this is papillae. This is papillary core composed of fibrovascular core, fibrous tissue, with the blood vessels, and these papillary core are lined by these neoplastic cells. So again, this is a very prominent papillary core. We can appreciate the papillae, and they are all lined by this single layer neoplastic cell, and all the areas showing us similar features. This is a slide of embryonal tumor medulloblastoma compared with the other previous slide. In this magnification, we can appreciate that it is so blue. They are so hypercellular. They are very hypercellular. The cellularity is so high that you can appreciate that the slide is blue in low power. And when we go closer, the cell is packed. They appear blue because we can only appreciate the nuclei. They have this scanty cytoplasm because embryonal tumor composed of primitive cell. The primitive cell display small cell with scanty cytoplasm. The cytoplasm is scanty, very minimal, until we can only appreciate the nuclei. That's why they appear bluish, because of the nucleus. And they are compact and crowded. We can't really appreciate the presence of cytoplasm. There is no cytoplasm, very minimal cytoplasm. They are crowded and very close to each other. When we see this primitive looking cell, usually the differential diagnosis is lymphoma or other embryonal tumor because of this primitive looking appearance of the cell. All the slides show us similar features, and depends on the variant of medulloblastoma. You can appreciate there is a presence of area in which they show a neuronal differentiation. At the center is an area with neuronal differentiation. This area is different from the other area because in this focus, you can see that there is a presence of quite appreciable amount of cytoplasm, because you can appreciate the presence of background eosinophilic cytoplasm, and the cells is not so crowded compared to the adjacent surrounding tumor, in which these tumor cells is very crowded, packed close to each other. They have minimal and scanty cytoplasm. This is one of the variant of medulloblastoma, desmoplastic medulloblastoma. But I think you don't have to give the variant. When you see a primitive looking cell in which the cells are small with scanty cytoplasm, and you see that this is a tumor arising from the posterior fossa in children, we can easily diagnose this as a medulloblastoma. I would like to share with you the meningioma. In this view, we can appreciate the architecture of the meningioma. It arranged in lobules. Sorry. Composed of multiple fragments, you can appreciate there is a 4 fragment of tissue here. They are all harboring tumor, and the tumor is arranged in these lobules separated by septae. You can appreciate the nesting pattern of the tumors, and it exhibit whirling pattern. They are uniform, round to oval cell. With many of these cells, you can appreciate there is a empty clearing nucleus, and the cytoplasm is syncytium, because you can really delineate the cytoplasmic membrane. They appear like they are sharing the cytoplasm in between the cells. This is different with the background fibrillary, in which the fibrillar background in the glial associated tumor appear like a very fibrillar background, and in this meningioma they appear like they are sharing this eosinophilic cytoplasm, because you can't really appreciate the outline of the cytoplasmic membrane. And of course, you need to correlate with the radiology features of the meningioma. And this is lobules and whirling arrangement of the meningioma. They are uniform cell, and sometimes we can appreciate the presence of samoma body. This is another case of meningioma. I just would like to show you the presence of how a samoma body look like. Okay, the rounded structure that have lamellated appearance, they appear more bluish. For example, at the center, the rounded structure, this rounded structure is a samoma body. We can frequently see this structure in a meningioma. This is another smaller samoma body. This exhibit a better samoma body. They are lamellated structure. This is multiple samoma body. So this is one of the characteristic of meningioma. This is very beautiful samoma body. And our last visual slide that I would like to show is schwannoma. In this view, you can appreciate that they are very circumscribed, well marginated, they are encapsulated, and this is in continuation with the nerve. Okay, in this view, you can see that they also have this bifacet pattern, the quite a cellular pattern, we call it as Anthony A, and the loose pattern, we call it as Anthony B. And in the Anthony A area, the cellular area, usually we will see these vertical bodies. You can appreciate the palisading of the nuclei, this at the center, with area alternating with area of enucleated. This is better appreciated in this view. I believe there is many vertical bodies. We need to find vertical bodies in the cellular area, in the Anthony A area, and the cell exhibit elongated, oval to elongated, with eosinophilic cytoplasm. We can appreciate the background eosinophilic cytoplasm, and over here is another vertical bodies, many vertical bodies here at the center. When the nuclei is arranged palisade at the periphery, we can appreciate the presence of the enucleated zone at the center. So this is what we call as a vertical bodies. There is, at this view, you can appreciate many are try to forming big vertical bodies. And in the loose Anthony B area, the cells are more rounded. The background is very loose. And the blood vessel in schwannoma usually highly nice. Okay, I think that's all for my video, for my practical of the CNS tumor. I hope that this video will give you benefit and better understanding in terms of the gross and histology features of the common CNS tumors. Many of the pictures are taken from an internet source and also books, includes Pathology, and visual slide from a website, your University of Leeds. So I would like to thank and acknowledge them for all the content in my video.